Biliary obstruction really isn't a disease on its own, but it will present in the setting of multiple types of diseases. So it's important as a sonographer to recognize biliary obstruction, be able to kind of figure out where that obstruction is happening, so then you can go and see if you can find the pathology that is causing the obstruction. So let's take a look at where common obstructions occur and some normal measurements. So the definition of obstruction is really just some sort of blockage within the biliary tree. And we know that these can be either from intrinsic or extrinsic sources. So intrinsic is going to be a stone within the bile duct, a tumor within the bile duct, something in the bile duct blocking it, where extrinsic sources are going to be something outside of the duct pushing it shut. The three common places that we see obstruction are intrapancreatic, suprapancreatic, and at the porta hepatis. So intrapancreatic obstructions occur at the pancreas, and it's going to be something within the pancreas that is causing that obstruction. So maybe it's a stone down at the pancreas head, maybe it's a pancreatic tumor, possibly pancreatitis even. Pancreatitis makes the pancreas enlarge, and so that enlargement of the organ can then kind of squish down on the common bile duct. When we are thinking about how that bile duct system will be dilated then, we consider down at the pancreas the distal end of the biliary tree, and in the liver being the proximal portion of the biliary tree. And then we also consider intrahepatic ducts being within the liver, extrahepatic ducts being outside of the liver. So when we see intrapancreatic obstruction, what we will typically see is complete dilation of the biliary tree from the extrahepatic ducts through the intrahepatic ducts. Suprapancreatic then moves us to the portion in between the porta hepatis and the pancreatic head. So now we're looking in this very small space, and there aren't a whole lot of things that can pop up in that area. What we will typically see though is adenopathy. Adenopathy is the enlargement of a lymph node. So this again is going to be an extrinsic force. That lymph node enlarges, pushes on the common bile duct, causing that obstruction. Because this obstruction is kind of in between the intrahepatic and extrahepatic area, we're going to see the intrahepatic ducts dilated, and we're going to see a portion of the extrahepatic ducts dilated proximal to that obstruction. The last area that we typically see obstruction at then is at the porta hepatis. So we call this porta hepatic obstruction. And this is typically caused by a tumor at the porta hepatis that compresses the bile ducts and causes intrahepatic dilation. At this point then we would see a normal extrahepatic duct. To know your normal measurements is going to help you then define when something is dilated. So intrahepatic ducts, we typically can't see them. So if you think about when you're scanning your liver on your normal patients, you might be able to see the portal veins, you probably see some hepatic, and if you were to put color on, you'd probably see where the hepatic arteries are running. When the intrahepatic ducts are dilated, what you'll start to see are kind of these double channels running through that portal triad. So again, typically we can't see intrahepatic ducts. When you start to see them, they are dilated. So typically they'll start to measure over that 2 millimeter mark. 2 millimeters is kind of our cutoff for what we can see on ultrasound just due to our resolution on our machines. As we move to the common hepatic duct, then we expect that one to measure less than 4 millimeters. As we start to get into the 5 millimeter and plus range, or 5 millimeters is kind of borderline. Anything above that is definitely dilated. And as we look at the common bile duct, we give the common bile duct a little bit more room before we start to call it dilated, and that's for a couple of reasons. First, once a patient has a cholecystectomy or has their gallbladder removed, the common bile duct starts to enlarge and kind of acts as a secondary gallbladder. So it can kind of act as a holding area. It'll start to fill up with bile and then will release as the body needs it. The other thing that we see that causes common bile duct dilation is simply just age. As the patient ages, we expect to see an enlarged bile duct. So after the age of 60, we can add 1 millimeter per year. So a 6 millimeter bile duct is normal for a 60-year-old, 7 millimeter would be normal for a 70-year-old, and so on. We do then finally consider the bile duct enlarged at 10 millimeters. I was actually just recently scanning a patient that she was a little bit older. I think she was in her late 70s, but started scanning through the liver, and I could see those double channels running along through the portal triad. And then I got to the common hepatic duct, and that measured, I think that was around 8 millimeters. And then her common bile duct actually measured 12 millimeters. So there's just a lot of extra tubing that runs through there, and it'll catch your eye when you see it. You will definitely notice bile duct dilation. Clinically, these patients will come in with right upper quadrant pain and jaundice. Once the biliary tree is obstructed, that bile starts to back up. Once it no longer can flow through the bile ducts, it starts to back up and leaches into the blood. And then the bilirubin in the bile starts to travel through the body, causing the patient to turn yellow. So anytime we have some sort of obstruction in the biliary tree, jaundice is definitely going to be a symptom. Let's take a look at then what dilated bile ducts look like on ultrasound. So as I had mentioned in my story, you'll just start to see what we would consider like just too many tubes. There's too many things running through the liver. And when you see these double channels running through the portal system, you can start to suspect some sort of dilation of the intrahepatic ducts. So the picture that we have here is showing very, very dilated ducts. These are very obvious. They usually are a little bit more subtle than this. Use your color to pick out where the hepatic veins are, where the arteries are, where the portal vein is. And if you still have this anechoic parallel channel running through there, then it is safe to call it a dilated intrahepatic duct. When we're looking at the extrahepatic duct and looking for dilation, this is a very common thing that we will see. And it is important to recognize which structure you are looking at. So typically the common bile duct runs more anterior, and the portal vein will be posterior. Of course, you can always use your color then to prove which one is the bile duct versus the portal vein. Make sure that you are showing good color flow through your portal vein so it doesn't look like there's any sort of thrombus within there. You do want to make sure that you are taking a good look through your common bile duct. See if you can see a stone or sludge or tumor. See if you can find that reason for obstruction. As I mentioned, that presentation of bile duct dilation is very, very common to the point that it actually has its own name. So we call it the shotgun sign. If you think about a shotgun, it has the two double barrels. That's kind of what this represents. Again, remember that the arrow is pointing to the common bile duct, which runs more anterior, where the portal vein has the arrowhead and is more posterior. So when you're thinking of biliary obstruction, make sure that you are able to recognize where obstructions occur, be able to describe what might cause obstructions, and what the biliary tree will look like based on where that obstruction occurs. Also know what the shotgun sign is.